So, Dr. Amitesh, you will moderate the meeting. So, AJ, Dr. Amitesh will moderate the meeting while I will talk. He has so much, he's electrophysiologist, so he has so much we have so much to learn from him today. Now that we're able to get him here amidst all his busy schedule. So Amitesh, it's a real great privilege to have you here after many years of not seeing each other. Today, I can see you one-on-one. I'm happy to see you, and everybody in the group is also very happy to see you. As an electrophysiology, we have so much to learn from you on the field of cardioversion and defibrillation today. I am sure there are things that we are going to raise today that you will clarify us on how those things, what actually did they mean, and what's those terminology, what did they apply for, and how do we use them?
Sure.
So we have
absolutely.
so much to learn from you, sir.
You're right. Let's start now. I'll be more than happy to take care of the doubts if there are any.
Good. So I can share now. So everybody can see my slides?
Yeah.
Yeah. So I will be talking in the next 40 minutes on defibrillation and cardioversion. So
hello. Hello.
So what we just play is it tells us about how the defibrillation and cardioversion goes. So we are going to take time to explain to us in the next 30 to 35 minutes on issues of cardioversion and defibrillation. Now, the first thing I want us to bear in mind is that nobody is born with a bad reading. Most bad reading, they'll end up in intrauterine death and they don't come up. So the normal pathway for anybody to survive and maintain his normal daily output is from the SA node, the sinoatrial node, we generate the impulse, and this impulse travel down and activate the two atria and converge at the point of the AV node. And at the point of the AV node, there is a delay of about 0.1 second, and which now move further to activate the atrium, and we can see here. So this, the beautiful diagram we see here is just telling us about the physiology of the myocardium, especially the ventricles, that you have contraction going at various levels. The sodium, we have phase 1, phase 2, phase 3, phase 4, and the rest of them. No time to explain. But here is what I want us to take home on this diagram is that when you add to cardiovert, there is a window in the cardiac cycle for you to do that, and the window is on top of the arrow wave. Now, between the Q wave and to the peak of the T wave is the absolute refractory period, and that is the point where you can cardiovert, and you will not turn that patient to a later reading that may kill the patient or may put you into more trouble. For example, between the peak of the T wave and when the T wave elapse and become isoelectric is what we call the relative refractory period. The advice is that don't cardiovert at that point. If you cardiovert at that point, that patient may enter into a later reading that may be worse than what you saw in the before cardioversion. The reason here is that some of the myocardium have already depolarized and waiting for another action potential to come. And if you pass in any current, it may activate those myocardium to generate a later reading. So don't cardiovert at that point. Most of the later reading in the myocardium, they usually run a loop, and this is one of them. So if you look at the guidelines of both the Americans and the European, in advanced life support, there are indications for defibrillation and indication for cardioversion as CPR and other advanced measures to keep that patient is ongoing. This shows us a very suitable diagram. But suffice it to say that we have 2 readings that we defibrillate. These readings are pulseless ventricular tachycardia, torsade de pointes, and ventricular fibrillation. These are the readings that we defibrillate. Every other reading is either we cardiovert or it is a non-shockable reading. So the incidence of cardiac arrhythmia critically increases, especially among in the ICU or in the cath lab. We frequently encounter them during PCI, during cardiac devices, because I've recorded some cases in the cath lab. We're doing a CROT, while after in the process of positioning the into ventricular tachycardia, and we have to shock that patient immediately and continue with our procedure. So we encounter them from time to time in the cath lab. So defibrillation is a non-synchronized random administration of shock.
Dr. Emmanjuel, you're not audible.
Yeah, Dr. Edafe.
You're not audible.
Yeah. He has network problem, most likely.
Yeah, it looks like he hopped off. We'll wait till he hops back on. I guess in the meantime, do we have any questions from the group?
Yes. Good evening, all. Good evening.
Hey, I'm back.
Okay, you're welcome.
Yeah. AJ, can you make me host again?
Yes, sir. Just 1 second.
Yeah.
Okay, there you go.
Good. Okay. So, yeah. So in defibrillation, you can apply it at any point within the QRS complex, while in cardioversion, you have a specific point to apply it. And that is why we do synchronization in cardioversion. Synchronization helps you to know that the dots are on top of the QRS complex, on top of the arrow wave in the cardiac circle for you to apply your shock. Now, in the 1956, alternative current were used for defibrillation, but as at later on in 1962, the direct current were later introduced. Today, defibrillation is part of the advanced cardiovascular life support in both the North American and also the European guidelines and every other society guideline today, because it saves lives and it has been proven to do so. Now, cardioversion, as we said, refers to the delivery of electric shock that is timed to the peak of the arrow wave on the EKG. So that is how one of the difference between cardioversion and defibrillation. It's a synchronization ensuring that electrical stimulation occurs only in the refractory period of the cardiac cycle, not in the relatory. That is the absolute refractory period, not in the relative refractory period. We should note all those terminology. So over the years, we started with what we call the monophasic, and now we have the biphasic. I will explain it shortly. But before then, if we are looking at type of defibrillators, what we have today is what we call the energy-based defibrillator, which send in energy to knock out the rhythm that is there, allow the heart to generate its own rhythm, which probably is likely going to come from the sinoatrial node. But you also have other form of defibrillators like the impedance-based or the current-based defibrillator. Maybe later on, Dr. Amitesh will take some time to explain this to us. Then, as we said, we also have the monophasic, which may come in form of damp sinusoidal or truncated exponential. Damp sinusoidal is that when the current goes, it takes gradually, it dies off. It doesn't die off spontaneously. If the current disappears spontaneously, it is termed truncated exponential. Then we also have, but remember that it's in monophasic, the current moves only in one direction. It doesn't move to and fro. While in biphasic, the current goes from positive to negative, then reverses back again. It can also reverse back again. There is also the issue of triphasic, but it's not in clinical practice, and it has not been shown to be better than biphasic. So monophasic and biphasic. In monophasic system, the current travel, I've said, is only in one direction. Either you use the paddle or the pad. Any form of that can give you that. While in biphasic, the current travels from positive to negative and reverses back. And in biphasic, we use smaller amount of energy compared to the monophasic. So with monophasic, the rate of first shock success is around 60, while in biphasic, the rate of first shock success rises up to 90. Reason because of it travels and return back, and it can also return back again. So these are the benefits. We have various types of defibrillators in the market. We have number one is the AED. The AED, that is the external, automated external defibrillators. The automated external defibrillator, the first set that were actually in the market were the monophasic. But nowadays, most of the ones that are available now are the biphasic that are available. Now, what happened about this is that they are not actually developed for the doctor only. They are developed for the layman. They are developed for the marketplace. They are developed for the offices. They are developed for the industry so that you can do something before the paramedic gets there. That is why you notice that they are everywhere in town. It is, they can be found in marketplace, can find in supermarket shops and the rest of them. Reason that somebody had a sudden cardiac arrest, you can just place the pad and it directs you on what to do. Then the ones that are fully automated does the work itself. While the ones that are semi-automated, you need some assistance of the bystander to press on the button to help you and to give the shock. But it's also direct you. It reads this one reads and they talk back to you. Is it a shockable reading? Is it a not shockable reading? It gives you all that and you move on with them. So these are some of the reading we just looked at. First is the normal sinus reading. Second, you see monophasic ventricular tachycardia. If this patient is in cardiogenic shock, go ahead and shock the patient immediately. You also have a ventricular fibrillation, shock the patient immediately. Then you may also have premature ventricular contraction, or you may also have atrial flutter. If atrial flutter or atrial fibrillation, if the patient is in hemodynamically compromised, cardiovascular that patient immediately. So there are reading that will apply cardioversion, some reading will apply defibrillation. Now, the current European and the American guideline says that for atrial fibrillation, you cardiovert, you can start with 120 to 200, you start at a lower, and if that does not work, you escalate it, you raise it up. The atrial flutter, you can start with 50 to 100 and escalate it. While ventricular tachycardia, if it is a patient with a pulse ventricular tachycardia, you can start around 100 for biphasic, 200 for monophasic. While ventricular fibrillation and pulseless ventricular tachycardia, you start around 150 to 200 for biphasic and 360 for monophasic, if that is what you have there. Then for the external, automated external defibrillator, let's just spend a little time on it. So this term, as we said, is actually developed for the community, for the larger population. So both paramedics and the layman can make use of them. Just it requires little education, especially the ones that are fully automated. You just place the pad, tell you the position of the pad is written on that pad. You place it and it gives you the work, analyze the reading and gives you the work. So for those that are semi-automated, as we said, you require an assistance of the bystander to press the button, but it gives you the analysis, talk to you. Is it a shockable reading? Apply shock, then you apply shock. But the question is that it gives you a little timing before you can do that, because you require a human effort to do to press on the button. Then it's also being used by the paramedics because they are trained to go into the community and get this patient while transporting them to the hospital. They can use that and apply shock when necessary. Then for the fully automated, it's mostly by the bystander. You don't require much, but the problem here is that when you are doing CPR, a bystander is doing CPR, it can give a shock and the shock may coincide with somebody doing CPR at the same point. That is one of the disadvantages of that. So you can see the one that is semi-automated, the parts are fully applied and it talks to you. Once you on the machine, it gives you the guide, it talks to you, then you apply the pad, one at the right side, just below the right clavicle, the other at the apex around 5, 6 or mid-axillary line. You apply it around there and the shock pathway goes between the two pads. This is a manual defibrillator. You want to defibrillate, you can still use the same pathway to defibrillate that patient. So what are the indications for cardioversion and defibrillation? One is that for you to defibrillate, you require those two readings, pulseless ventricular tachycardia and ventricular fibrillation, because there is nothing going to the brain at that point in time. So start your CPR, defibrillate, and continue your CPR until that patient has normal sinus reading. Then if a patient has AF and or atrial flutter or atrial, what we call atrioventricular reentry tachycardia, or AV nodal reentry tachycardia with pre-excitation pathway, or monophasic regular tachycardia with a pulse. You also need to shock them if they are if they have hemodynamically compromised, or you try chemical cardioversion, it did not work, then you have to try electrical cardioversion. For defibrillation, it goes for pulseless ventricular tachycardia, ventricular fibrillation, and torsade de pointes. So all these are readings that we address in the cath lab or in the ICU. And while that is going on, CPR must also go on with them. But suffice it to say that it is not only in the acute, especially when you are talking about these supraventricular tachycardias. There is for AF, if AF has been long and you try chemical cardioversion and it did not work, and you have adequately anticoagulate that patient with your transesophageal echo done, you can also attempt that patient to cardiovert them, whether they will go into sinus reading. Yes, I have done some of that, and we have had some good sources from AF who didn't respond to chemical cardioversion, but they responded to electrical cardioversion, especially when the atrium is not that big, less than 5 cm. 5 cm. They respond well to that. Okay, so ability to recognize is very important. So that is ECG, and also to recognize each of these reading and know when to apply cardioversion or when to apply defibrillation is very, very important. And the earlier we do it, the more success we give to that patient in terms of survival. Because the more we delay, the less chances of having success for such group of people. So for atrial fibrillation, let's just take a few minutes to talk about it. There are various types of atrial fibrillation. We are not going into that, but my emphasis on this talk today is on, is it an acute or the atrial fibrillation has stayed for some time? If it is an acute and the patient is hemodynamically stable, you can try your chemical cardioversion with your beta blocker, your amiodarone. These are the two agents we have here. But if you are to do cardioversion of AF in acute setting, you have to use your IV beta blocker. But in the Nigerian setup, because the aim of this presentation, the aim of this group is for us in the sub-Saharan Africa to know what we have and to make use of what we have and know where our deficiency is. We don't really have commonly the IV beta blockers among us here in Nigeria. What we have here is more of amiodarone. We have the IV amiodarone everywhere, but IV beta blocker, we don't have them that we use for cardioversion, not labetalol. We're talking about metoprolol IV. We're talking about bisoprolol IV. We're talking about, we don't have those medications around here, but we have the oral form. So we can still attempt the oral combined with amiodarone, and it gives us some form of success. And if you try that, you do that for a while, and you anticoagulate that patient to ensure that that patient doesn't develop a clot, and you come back to cardiovert that patient, you have a chances of having some success, especially when the atriums are not that very large. So you can have some success with that. So this is I got this this ECG from Life in the Fast Lane. That is where I got it from. So the reading here is a fine AF, an AF, and this patient is hemodynamically compromised. What do? We just have to cardiovert. Cardiovert, and apply your medication and move on with it to see whether the patient can be helped. So we also have atrial flutter. The treatment of atrial flutter and that of AF are similar in the guideline. It's still the same thing we do for them. But when the electrophysiology we talk, it will give us some more insight on the issue. Now, cardioversion of AF doesn't mean that the patient may not reverse back to AF, because I've seen it, or flutter doesn't mean that the patient may not reverse back to flutter again. So if that happens, what do we do? Then these are where electrophysiology comes up. You can ablate the pulmonary veins, where most time is the source of the AF, or ablate around the source of the atrial flutter, so that you'll be able to keep that patient in sinus as much as possible if the need arises. Now, for narrow complex tachycardia, including atrial flutter, atrioventricular, not reactory tachycardia, atrioventricular reciprocating tachycardia, or junctional tachycardia, once they are hemodynamically unstable, the guidelines say cardiovert them straight away, and cardioversion is recommended for them. But if they are hemodynamically stable, you can try chemical cardioversion with the beta blocker, the amiodarone, the antiarrhythmic agent. You can try that first, and if that don't work, then while doing that, you also anticoagulate that patient. Why that didn't work, then you can think of cardioverting. But there are some centers that, whether they are hemodynamically stable or not, they try to cardiovert to see whether the patient. But the issue here is that if you are cardioverting anybody that is fully conscious, first you have to sedate that patient to ensure that the patient is not fully conscious. Then two, you have to also apply gel to the part so that the energy you are applying doesn't burn the skin. So this is a slow, fast, typical AV nodal reentering tachycardia. Then here we also talk about similar thing here. Then we talk about the monophasic ventricular tachycardia with a pulse. In monophasic ventricular tachycardia with a pulse, what the guideline recommend is for us to cardiovert, not to defibrillate. So we still use a lower energy synchronize and cardiovert the patient. So you can see that it's a monophasic because most of the arrow waves, most of them are all similar in amplitudes. So it's monophasic. This is also another monophasic, yeah, similar and all pointing towards one direction, maybe probably pointing that is coming from one source. Then for patients with ventricular fibrillation and pulseless ventricular tachycardia, the treatment in the guideline is similar. Defibrillate that patient, continue your CPR, continue your medication until you restore that patient to sinus, and follow the patient up during the recovery to ensure that that sinus rhythm continues. This is a polymorphic ventricular tachycardia. Reason being that you can see that how many minutes remain? Is it up to 40 minutes, sir? Moderator, sir. 9 minutes, fine. I will finish so that we can discuss in detail. So this is monomorphic ventricular tachycardia. Reason being that you can see that the arrow waves are different morphology and different amplitude and the rest. So this is another, to side the point is polymorphic ventricular tachycardia. So after cardioversion, sorry, this is one of the rhythm that we must watch out for. That was why I brought it here. Why should we watch out for it? The arrow on T phenomenon. So there is a sinus rhythm with a frequent PVC. So when you see this type of ECG on a 24-hour Holter, or you see it on a patient on a monitor, watch out for that patient, because that patient is on the verge of entering into either a VTAC or a VF, very common, arrow on T phenomenon. This is another patient with torsade de pointes. Yeah, so this is the post-shock and what we saw here. Then you can just listen to this video. Sorry, let me go back to it.
You just carry load. That's like son me carry load. Stay close. You go that up and down.
Okay.
Let me say go wear that trousers with them.
Just keep eye on what is this, a sinus reading on the monitor. Suddenly the patient degenerated to ventricular fibrillation. So that is what I wanted to show there. So this tells us the various unstable ventricular, unstable atrial fibrillation use about 120 to 200 joules on the biphasic defibrillator. For monophasic, this is the recommended and is synchronized. Then for VF and postlet ventricular tachycardia is always unsynchronized. Use 360, 200 to 360, while you start with 120 and graduate up in biphasic defibrillator. So these are the things that I want us to pick up today. Now, the next thing is that how do we prepare the patient for cardioversion? For those that are fully awake, the guidelines say just sedate them. If you have midazolam, diazepam, just sedate them. But in the where there is an anesthetist and the anesthetist can give you a support, then the anesthetist can administer a propofol, but it has to be done under the guidance of an experienced anesthetist. But if in a situation you are in the cath lab, there's no anesthetist, we have our midazolam, we have our diazepam, you can give that, then you go ahead. But for patients who had a VF already, they are already unconscious, you don't need this medication. Or a patient who already had a pulseless ventricular tachycardia, you usually see them already unconscious, so you don't really need this medication before you go ahead. So apply your pads or your paddle, apply them appropriately. There are two ways you can have two recommendations. One recommendation is that you place it at anterolateral. That is one recommendation. While the second recommendation is posterolateral. Posterolateral is this one that this is a posterolateral. This is recommended for one, those that have ICD or devices, the guideline recommend this, or those that are pregnant, the guideline also recommend this. They also suffice it to say that if you are using a biphasic defibrillator, the energy is smaller compared to a monophasic. Two, the energy is mainly between the two parts. That is where the energy mainly stays along and traveled along. It doesn't scatter the way a monophasic scatter. So it's better also for pregnant women. So CPR before cardioversion is very important. Number one, it sends blood to the brain, and oxygen and glucose to the brain, and also send blood to the myocardium during CPR. Why? And that also enhances your defibrillation and cardioversion. Studies have shown all that. So application and delivery of cardioversion follow the step. First, you press on the button. Once you press on the button, then the next thing is that apply the ECG, and look at the reading appearing. Then also the next thing you will do is press the energy and select the energy that you will use. Then the next thing is that you press your synchronization. Then your synchronization, how do you know that the synchronization is on? It gives that button gives you a dot on top of the arrow waves. Then after that, you press your charge. Then you charge, once the charge is complete, then you go ahead and you cardiovert. But in defibrillation, you don't synchronize. So that is the pathway that we follow to do that. So once that is done, the patient is cardioverted or defibrillated, return back to sinus rhythm. And once the sinus rhythm is returned to, then you place the patient on recovery position, still be on the look and watch that patient and ensure that the patient doesn't go back. Continue the patient on medication and ensure that the patient doesn't return back. Then we talked about use of cardioversion or defibrillation under special circumstances like pregnancy or people with cardiac devices. Yes, you can do that. So among various people that are pregnant, you can do that. But as we said, use that, the guideline recommend more of anterior-posterior, not anterior-lateral for pregnant. Then two, if you have a biphasic are preferable. Then three, sedation is also very important to them. Then for ICD or for any devices, we also said that you can also do that, but avoid where the pulse generator is. So anterior-posterior is also very important for them. If they are fully conscious, you can also sedate them before you go ahead with the procedure. So can there be any complication from cardioversion or defibrillation? Yes, there can be complication. One, myocardial loss can occur. Myocardial injury, skin injury can also occur because of maybe probably not applying enough adhesive to the skin. Okay, I think this is the summary of my presentation today. It's now time to discuss. It's good we have our guru here, Dr. Amitesh, who will take us on the discussion.
Yeah, Dr. Emmanjuel, I would like to add a few points before we go to the doubts. See, there's a vulnerable period in the relative refractory period, which is the reason we look for sinking. Think as in the sink maneuver. Now, what happens is, if you, for a VF patient, doesn't really matter because the rhythm is already wavered. But on patients who have a re-entry phenomenon, as it's called, the re-entry phenomenon. So those people, if they are given a shock without sync, then what happens is those patients who are in a tachycardia can turn into VFs. You degenerate them into VFs. That's the reason that you do cardioversion with the sync on. That's called synchronized cardioversion or defibrillation.
Yes, correct.
Now, this timing is something somewhere between 80 to 100 milliseconds before the T and around 50 milliseconds after the T. So this is the vulnerable period. So if you are able to do the, your defib machine has that sync part, then it's very easy. But otherwise, you can actually observe, take it along with that notion that those seconds are important. One. Now, when you have an underlying device, you need to be around 8 to 10 centimeters away from the device.
From the device, yes.
Yeah,
correct.
So either it's a pacemaker, it's a ICD, it's a CRTD, whatever it is, you'll be around 10 centimeters away from it and you will be done. So the reason the anterior-posterior padding location is important is because sometimes what happens is we are looking at rhythms emanating from the left atrium. The left atrium being little posterior gives you that leverage that you take care of the left atrium as a whole. So the energy which goes from the sternum part, sternal area to the scapula takes care of that particular aspect of the left atrium. So you can try to revert a atrial rhythm to a normal sinus rhythm. Now, coming to the usual atrial suspects. the AVRTs and the AVNRTs, you should always, until and unless they're hemodynamically unstable, usually don't follow a cardioversion sort of a thing. It's usually either adenosine or calcium channel blockers that we usually try. But as soon as you have a BP systolic going to less than 90 millimeters, you are supposed to shock them as well. These rhythms, the AVNRTs and the AVRTs, they do respond well, but when it comes to any tachycardia, which is more junctional, they don't respond. That's why something like a paroxysmal junctional re-entry tachy, PHARTs or junctional tachys, you don't cardiovert them. Now, when you have devices, you know that the patient is in AF or whatever. So, for example, in a CRT, you want more than 95% pacing. So in these cases, even if the patient is not symptomatic for any reason, you can, ask the person to come over because the CRT is not doing its bit. So you prepare them, get a transesophageal echo, rule out a LA clot, and then cardiovert them. So that takes care of the real aspect of a CRT, which is to pace as much as possible. And there are lots of points I really would love to make, but I think there's a question in the chat box about to Dr. Emmanjuel, that do you pace rhythms for do you overdrive them to pace terminator atrial flutter with device? So yeah, you want to take that call? Should I?
Yes, you can make your contribution, but what I wrote there is yes. If that patient had a device, you can overdrive that pace. You can overdrive, and if it doesn't work, then you can prepare the patient. And as you said, if we have a transesophageal echo first, because one, you should know the duration of that reading. And if the duration is long, you want to be sure that the patient doesn't have clots in the early appendage. And if that is there, you have to anticoagulate the patient for a while and repeat the transesophageal echo. And if it's not there, then you can go ahead and cardiovert. With electrical cardioversion, if you have done your overdrive pacing and it didn't work. But the question, what I want to also add to that question is that it's not every pacemaker that had that software to give you overdrive pacing. I know in India you have all the generations, and the latest generation is with you there. But here, what we have before now, or what is being sold to the sub-Saharan Africa is Sensia, and lately we now start having Sphera. The Sphera we are getting here don't have that ability to overdrive pacing. So if you have a device that cannot give that, then you still resort back to what we are saying of cardioverting them electrically, or you use the usual pathway to follow. So it's still the same thing. But Azure, Adapter, Azure, these are Medtronic various devices. They have this algorithm in them where you can overdrive the atrium and give you success sometimes. But these devices are not sold commonly here. Yeah. This is where my issue is. So over to you, Dr. Amitesh.
Yeah, you've brought out a valid point. It is all about the capability of the device as well to pace terminate. It's usually with the ventricular rhythms in ICDs or CRTD, which you are able to do a little better than the usual atrial pacing from a pacemaker point of view. Yeah, it's pretty valid from your side as well. Good. If there are any questions, we'll be happy to take.
Yeah, thank you very much. Good evening.
Good evening.
Yeah, thank you very much, Dr. Edafe, for wonderful and the good teaching. I have a couple of questions and need for clarification. Number one, it is clearly explained of when do we defibrillate. That one has been very clear, but it's not very clear of when to cardiovert instead of defibrillation. So we need a repeat and more clarification of when to cardiovert instead of defibrillation. Number two, we learned that during the cardioversion, we use the think mode. We turn the think mode, and then when we see the dot appear on the R wave, then we shock, isn't it? So if there is, it means those without the think mode, we cannot cardiovert if the defibrillator has no think mode, because there are olden days defibrillators and some of the monophasic that they don't have the think mode. So that means we cannot cardiovert with that one, or there is a way, even if they don't have think mode, that we can cardiovert. Then number three, I learned that somebody, I learned, was it last week or last week, that some of the paddles, they can be used to trace ECG without even need of you to attach the ECG cables. But you can use the paddle. The moment you touch the patient with the paddle, then the ECG will appear. But I know that the ECG that we have commonly, you have to attach the leads before you start seeing the rhythm, and then you take action. But is there any modern one that when you attach the paddle alone without the ECG cable, you will see the rhythm going on and then you take decision? So these are my 3 questions or need for clarifications. Thank you.
Thank you very much, sir. Yeah, Dr. Amitesh, you want to take some, then I take some.
Yeah,
good.
So let me take the third one first. See, the earlier devices, those who had paddles, if you just keep the paddles, for example, a patient has come to the emergency with unconsciousness and you suspect that it's a pulseless VT or a VF. So if those machines are with those paddles are kept in the anterolateral side, as in the close to the sternum, the left one, the right one close to the apex, they can actually show you a single lead ECG on the monitor. That's good enough for you to shock the patient if there is a hemodynamic compromise. So the need for ECGs and all the preparation sometimes is something that is pretty elective. But you have machines which have only the paddles giving you just the ECG, a single lead ECG to take care of the shockable rhythm.
Thank you. Yes. Thank you very much.
Then,
coming to the cardioversion part. Now, cardioversion is again something that is both emergent as well as elective. Now, if you have a patient of atrial fibrillation or atrial flutter coming to you with a BP of 80/60, he is feeling dizzy, he's sweating, he probably is going into a breathless mode or perhaps into heart failure, you don't have time to prepare something. Now, this is the patient who you can cardiovert. Why? Because first, as a person who knows what the ECG looks like, you can take a call. Now, in these patients, what you need to remember is once you've seen the rhythm and you know that it's an atrial rhythm which is causing all the compromises, you can go to the sync mode, go for the charging, and revert it if with the first shock and if required with the other shocks, whatever be the need. Now, if you are looking at a patient who is hemodynamically compromised, you don't want to give more than 1 or more than 2 shocks because the rhythm you need to revert as early as possible. So that's when you do a 200 joule biphasic or a 360 joule monophasic, whatever be the machine available to you. So you cardiovert patients of atrial rhythms, you defibrillate the patients of ventricular rhythm. Now, ventricular rhythm means the patient either with a monomorphic VT with hemodynamic compromise, a polymorphic VT with hemodynamic compromise, VF with hemodynamic compromise.
Thank you very much. Thank you very much for this clarification.
And I forgot your second question. What was the second?
Yeah, the second question was that if you have a defibrillator that has no sync mode, can you cardiovert, or it has to be the one with sync mode?
Yes. So most defibrillators as of now, or perhaps even in the last 20, 25 years, have that sync mode. The sync mode was specifically meant for the technical reason that with the same machine, you can both cardiovert and defibrillate. So when it was made to see the ECG on the monitor and take it as if, you can do the sync mode whenever you require.
Thank you. Grateful.
Yeah, good.
Yeah.
So in addition to what Amitesh just said, you know that AED is a defibrillator, but is an automated external defibrillator. Then the ones where have the sync mode are the manual defibrillators. Now, these manual defibrillators, they can have a paddle. You can also organize them and plug them to a pad, other disposable pad. The paddles are those iron-like handles that you hold. You can rub them on its surface rub gel on the surface and apply it. While the pads are those adhesive electrodes that you can apply, disposable, you use once and you throw away. So this manual defibrillator, which can function as a defibrillator, can function as a cardioverter, can also function as cutaneous pacing. You can also use it for pacing. It has all these modes. And also you can also use it as a monitor. You can also use it as a monitor. It gives you all those functions. But for the AED is only meant for defibrillation. AED does not do the work of cardioversion. And there are two readings which we have explained that it does. Thank you.
Thank you very much.
More questions. Thank you, Dr. Nazi. Great time.
So, Dr. Edafe, that means we should be counseling the policymakers and administrators when they are purchasing those machines. They should contact the end users and the specialists, for example, to get the machine by phasing, sync mode, and the pacing modes. So this is the best defibrillator. It has the pacing mode, it is biphasic, and it synchronized. So, but sometimes you see the policymakers and the administrators, they just go and get contractor and bring monophasic, no pacing mode in it. And you have to work with what you see in the hospital, and it doesn't all go well. So I think we have a work to do to convince them. Always consult the specialist.
Yes, I agree with you. No issue. All manual defibrillator has all that. The pacing mode, the defibrillator, all manual defibrillator, I think they have it. It depends on the manufacturer. It's Philip, Biotronic, what have you, all of them, they have it.
Only that we prefer biphasic than monophasic.
Yes, correct. Yes.
Can I just contribute to the third question I was asked regards
correct.
the ECG? Thank you, sir. So you asked about ECG, or you mentioned that the ECG, you can get your ECG by placing the paddles on the patient. Yes, that is very correct, but it depends on the settings of your defibrillator. So it depends on if your defibrillator is programmed or set up to extract ECG from just the ECG cables. You would not see, depending on the model too and how recent it is, you might not see the ECG when you place the paddles. So you have to either set it auto so that it will select whether it's the paddle or you connect the ECG cables, whatever is connected, or it is even the pad, whatever gets connected from the defibrillator, either the ECG cables, the paddle, or the pad, it will show you at least a single lead ECG, which you can work with. So that depends on how you set the defibrillator. Just want to mention that. Thank you.
Thank you very much.
Thank you.
This is valuable contribution, actually. Thank you.
Thank you, sir. So more questions, more talk. We have talked about defibrillation, talked about cardioversion in our everyday work. We encounter this issue, we encounter them. So let's ask our questions to clarify them.
So before anybody puts in a question, let me give a few more insights. Now,
good.
What is meant by a successful shock? Now, a successful shock is a term which is used that after you've shocked a rhythm and the rhythm doesn't return within the next 5 seconds, is considered a shockable rhythm. Now, it can happen that the rhythm returns after 10 seconds, but that doesn't mean that the shock was unsuccessful. It's just that the shock is recurrent. The rhythm is recurrent. 1. 2. Now, in patients, sometimes what happens is after you give them a bit of sedation and you anesthetize them, you've brought back the rhythm, but the patient goes into a sleep mode, as in it doesn't wake up. So that's again a complication of anesthesia. That's why they say that whatever you choose as an anesthetic agent should be based on whatever the clinical profile the patient has. Now, if the patient is elderly, you might not be looking at too much of midazolam or too much of diazepam. You might be looking at just a bit of analgesia by a small dose of fentanyl and you are done. Because what you want to do in a patient who is cardioverting is you don't want them to remember the pain that they might have because of the shock that you give them. In such cases, a small dose of any agent will do, which just takes care of the next few minutes while you are providing a 100 joule or a 200 joule cardioversion. Now, when we talk of pain, so after 50 joules till about 200 joules, the pain almost is the same. The only time the pain might be less is when you give a 25 joule, which is usually the cases when you are looking at something like an atrial flutter. But otherwise, you shock them with a high energy because you don't want to shock them more than once or more than twice. Now, Dr. Emmanjuel talked about IV beta blocker and IV amiodarone, but there's something called pill in the pocket. You have oral agents which take care of the rhythm, the AF part. It's a combination of flecainide and propofol, pretty much available these days. That is one aspect. The second aspect is something called an IV ibutylite. It is also being available. It's for chemical cardioversion. You can try it first after you've ruled out a clot, and you can think of a chemical cardioversion before doing a mechanical cardioversion. The success rate is pretty okay, although it's not available everywhere, but you can have that. So a patient who is planned for a cardioversion has to be anticoagulated for at least 3 to 4 weeks prior an elective cardioversion. And after the cardioversion has been successful, it should be continued with at least 4 weeks. Rest of it, do you continue after 4 weeks? Anticoagulation is more dependent on what the rhythm stays. So that's why you work a workup of the patient in terms of a Holter or ECG and stuff like that. You should continue with it till you are pretty sure that the AF has not come back or you have taken care of it. Now, once you see the LA size on an echo, you can actually decide if your cardioversion is going to be successful, but everybody should be given one chance at cardioversion. And LSI is between 4.5 to 5.5 is just about okay. When the LSI increases to more than 5.5, you're probably looking at a recurrence in the coming few weeks or months. So the higher the LSI is, the more chances that the cardioversion might not be effective enough for a long period of time. Now, anticoag, if you have atrial fibrillation pre-acute, in the last 48 hours, it was not there, now it has come up, then you don't need to anticoagulate the patient. You can straight away go to the cardioversion part and probably continue anticoagulation later. But if it is more than 48 hours, then you probably need to confirm, either give, if it's an elective, you give him 4 weeks of anticoagulation, then cardiovert, or you get a transesophageal echo to rule out clots inside the heart, especially the left atrial appendage or the left atrium, and then plan cardioversion.
Thank you very much, sir. This arises need for 1 or 2 clarification, if you won't mind, sir.
Yeah, no problem. Please go ahead.
Yeah, the first one, how many cycle of defibrillation are we allowed to do for us to call it a day as failed defibrillation or failed cardioversion? That is the first question. And then the second question, when you have failed defibrillation, what do you do next?
See, every time you cardiovert or defibrillate, you are actually stunning the myocardium. So they say that even if it's a matter of 2 cardioversions or defibrillations, the third will set a stage for myocardial stunning. That is, you're trying to come to a condition where the heart might be getting weaker with every possible shock. But what to do? Now, if you have a VF patient who is not responding, is unconscious, you don't have a PT, you don't have a BP, and you continue with CPR. You continue shocking till you have either some benefit or you have enough time to make sure that the acidosis or the electrolyte imbalance or whatever it is being looked at, has taken care of. So there's something called a VT storm, a word where you are not able to do anything. But that is rare circumstance where your defibrillation might just fail. But after 2, in fact, they say between 2 to 3, you are not probably looking at a successful cardioversion or defibrillation, except in cases of VF where you probably will be looking at more number of shocks. But in cardioversion, if it's more of an elective case, you don't give it to more than 2 or maximum of 3 under IV amiodarone or IV beta blocker, or more of sedation. So whatever you want to do, you just stay put at around maximum of 2 or maximum of 3. That's it.
Thank you.
Thank you very much. Yes, question.
So I wanted to share this with you all. You had spoken about biphasic versus monophasic. I just think this is a good way to kind of visualize the effectiveness of a biphasic waveform over monophasic. So this is the total amount of energy required to cardiovert a heart. And this study shows that having either an equal phase, so first phase, second phase being equal length of about 5 milliseconds apiece, or having a longer first phase is shown to be superior to a monophasic. So total joules or total voltage required to defibrillate. And keep in mind that monophasic, not only are you giving more voltage, so you're causing more electroporation or damage to the heart tissue, but monophasic itself at an equal energy output is shown to do more damage to the heart. So a big reason why, if you have both options in your hospital, I would say you may want to default. I'm not a physician, but you may want to look for the biphasic opportunity.
Thank you.
Yeah.
Thank you. Thank you very much, sir.
And then one more, we had spoken about ATP or anti-tachycardial pacing. This may be a little bit in the weeds, but basically just showing how an electrical circuit can be interrupted with ATP. So just going 20 to 30 milliseconds faster than the cycle length or the total time between either ventricular events or atrial events that you're trying to break up, and gaining control of that refractory period and overdriving it, hopefully pace terminating the rhythm.
Yeah, I would like to add one thing in this. This is one function which is available in ICDs and CRTDs. Pacemakers usually, when you talk of the word ATP, they somehow have less of it. But yes, when you are looking at a monomorphic VT circuit, you have, your devices giving you those papers with that morphology. You can actually go ahead and the device does it for you, but again, you can also do it in refractory VTs.
To add as well, if they ever have a slower VT, you can use a pacemaker as a way to overdrive by programming the rate faster than the intrinsics. So there is obviously limitations with how fast a pacemaker can pace, but if they have a VT at 120, you can program them at 130 and leave it for a period of time programmed at the rate, drop the rate down and see if you've managed to pace terminate.
Yes.
But obviously you want to have defibrillation available just in case you initiate something worse. So
okay. AJ.
Yes, sir.
Yeah, can you explain the difference between bus and RAM?
Between what? I'm sorry.
Burst and
bus and RAM.
He's talking of the trains of stimuli.
Oh, gotcha. Yeah. So essentially ramping is your, if you're looking at the cycle length of the cardiac cycle with a ramp. So with the typical ATP, right, they're all the same cycle length in between these individual pulses. With ramp, within each train of bursts, it gets a little bit shorter every time. So it's just a more aggressive way to try to interrupt the rhythm. That's not very well drawn, but basically instead of having this equal timing between each electrical impulse, with ramp, you're shortening that up. So when you give ATP, you give it in a train or a bunch of electrical impulses to try to gain control of the myocardium, right? And then there's different ways you can kind of program within each of those trains to make it more aggressive.
Yes, because
sorry.
Because during the programming, you see bus, maybe they put it 2, 3, RAM, maybe 2.
Yeah, exactly. So you have different options, and we can kind of go into that in more detail, I think, later. But like the real premise is with ATP, you're not. There's more complexity if you'd like to be more aggressive with your programming, and this is within defibrillators, obviously. Yeah, you wouldn't do like surface. I don't know. I've never surface paced like that. But yeah, so there's different ways to kind of customize your ATP. So ramp is fairly aggressive. I would say I never use it typically, and except in very specific cases where it's shown to be effective for a specific patient. Will seem like adaptive, where it'll remeasure the cycle length of the last event after the first train of, so you give a train of ATP, it doesn't work. It'll remeasure the cycle length and it will adapt it to be a little bit shorter or a little more aggressive. But ramp is within each train, and it's a fairly aggressive way of, giving ATP, and it can be
giving ATP. Okay.
Yeah. So you want to be ready to defibrillate in those cases, because you could put them into an arrhythmia, a worse arrhythmia.
Okay. Dr. Amitesh, can you explain this wearable cardioverter defibrillator?
Which one? I didn't get your question.
Wearable cardioverter.
A
wearable. He's like a Zoll.
Yes.
So this has come up now in circumstances where you have the patient is not willing for an endocardial placement. There are defibrillators available which you can wear, where they are a bit annoying sometimes. But again, you have to understand that the impedance of the chest wall needs to be taken care of. So they are more specific for an individual. And in rhythms, in cases where you know that the hemodynamic compromise might be there, but the patient is not willing for an endocardial ICD, you can actually go ahead with a variable cardioverter defibrillator.
Defibrillator. Okay.
To add to that point, you may also see it sometimes for like bridges during extractions. So a patient has an infected device and they don't reimplant right away. They may give them a wearable just for the time as they get the infection under control before reimplant.
Okay. So there's no specific indication apart from being that you can use it as a bridge before implant of ICD.
No,
it's not for a long term. Is it for a long term use like an ICD?
In patients who have, very few recurrences, once in a year, once in 2 years, you can give them that option. But again, you have to understand that wearable ICDs are, they might not pace once they give a shock. The post-pacing radis are not taken care of with wearable ICDs.
Correct.
So there are a few options available in people who are very, stable, very less frequency of, the ventricular rhythms. There is a specific reason for you to give a variable ICD than the usual one, the endocardial ones.
Correct. Thank you, sir.
There is something that used to be available earlier was something called an internal cardioverters. So in patients who are undergoing bypass grafting and the chest is opened up, you suddenly find that the fibrillation, the ventricular fibrillation has come into play. So there were paddles which were earlier used. You could use it on, in your vision, to keep them on the epicardial surface of the heart and defibrillate, because you cannot use the paddles because the chest is opened up. So those are circumstances which are called the emergent, post-surgical complications can happen, but you need to be ready for them.
Okay. Thank you.
Here's you were talking about like when they're open, you may have seen some of these in the past too. Possibly. Yeah. So if patients or chests are already open, they may choose to implant.
Yeah. AJ, we don't have them in Nigeria. We don't have them here.
The sewn on, you don't see them much in America either. It's pretty rare. A lot of times we implant them transvenous. But back in the day, people used to do that. You may have also seen arrays. You may have opportunities to use arrays where they would do it would go to an implantable defibrillator in the chest. Then you would have underneath the skin, you'd have like an array that would allow you to defibrillation. So you have like ICDs, for example, use those kind of methods. And then also you have opportunities to use like a different positioning coils. We'll go over that a different day. I don't think that subject matter needs to cover. So
no, in addition to this, you probably have the subcutaneous ICD as well from Boston. Again, people who are in a position to carry it on the chest wall, perhaps. In people who have, venous access issues, in people who have had prior infections, you're probably looking at a subcutaneous ICD as well.
Yeah.
Yes, very important. Please, can you just throw some light on the subcutaneous ICDs?
No, this is
what makes them different from the transvenous implanted ICD?
You're not going endocardial. You are looking at a vector from the outside of the heart. But you're doing the same job an ICD does. So the amount of energy delivered, amount of work that you do, it's, somewhere between your back and between your front, you create a pocket for that big machine, and the vector is placed close to the heart subcutaneously, which keeps it going. But again, the issues are the same as your variable ones, the post-cardiac pacing. Sometimes you require them, you cannot do that. It's just about providing you with a shock whenever the need arises.
Okay.
And it's a big difference.
Do you require the assistance of the surgeon?
No, we've done it. Otherwise, it is possible. It's just that it needs a bit more of planning. It needs a bit more of planning. You need to tell the patient that this is perhaps the way we are going to do it, and these are the precautions you need to take, and this is the way we're going to proceed, and this is, it stays the same as an endocardial one, but it's just that you need to sharpen your surgical skills a bit more.
Yeah, sure. Okay, very important.
I would so I'll go ahead and show this just in case you may find it interesting. So we speak about like different arrays. And obviously, I think Julius and I can cover this on a different day where we're talking about defibrillators, but just to give you an idea, this patient has had many different revisions and work done. You can see an RV coil here. You can see an azygos coil, which is a more posterior position through the azygos vein that gives you a different vector. And then these are actually would be arrays that are subcutaneous. Here's another example, subcutaneous array. So this is all just trying to get a better vector of the heart. So when we talked about earlier, you were talking about putting patches on and paddles on, getting the proper vector. It's something to consider as well for internal defibrillators. If you have a massive heart, then one RV coil, this vector may not be enough to engage enough tissue. So that's why they may try to bring in like an azygos coil that gives you a more posterior aspect here, so you can gauge all the tissue from the RV to the more posterior vector there.
No, AJ, please explain it again.
Yeah, so basically, let me bring it back up. Sorry, I stopped sharing. So basically, in general, when just like with your patches, you want to have a good vector to engage as much cardiac tissue as possible. And there's considerations about where you'll put it. So some of these patients with extremely dilated hearts, or they could have, very, very muscular hearts, it could be kind of hard to defibrillate those. And we don't really DFT or defibrillation threshold test anymore. They used to do it at implants or post-implant to make sure the device could function. Nowadays, people just receive a device and they just send them out in the world and hope that it works. And statistically, it will, but there are patients who may have trouble. So in these cases, if you know they're going to be difficult or they've had failed shocks in the past, you can bring them in and try to add different hardware to get a little better vector. So there are ways you can program within the device, and I can't really speak to the other manufacturers, but within Abbott, that's where we can play with the biphasic waveform and how long you give each phase. So you can kind of try to cater that to the patient, which is what we call DEFT, D-E-F-T within Abbott. Other companies have some degree of programmability that I'll let someone else talk about. And then there's also ability to add hardware. This is obviously a little more invasive. So if we can program it within the device first, that's ideal. And then if not, we can come in and say, do we add an array? Do we add, a azygos coil? There are lots of different things, but it's all just trying to get the best outcome for the patient. And so on patches is always a backup, but you have to end up splitting the chest. So it's a lot more invasive than adding an array or adding an azygos coil.
Okay. Wow.
Now, this aspect is well taken care of. But again, as an interventional cardiologist, you're probably looking at a dual chamber ICDs in large hearts and assuming that they'll play their part before taking the route for the coil, because sometimes you have this option of putting in a dual coil ICD lead, the one which is there in the azygos and as well as in the RV. So as people who can, the first option is also always going to be what you can do endocardially, and perhaps go into a more invasive need if time and the other things permit.
Absolutely.
Okay.
Hello.
Yeah.
Sorry. Yeah, I just have a question regards invasive intracardiac defibrillation, post-op or intra-op. If we can perhaps throw some light on that, after the bypass surgery or any of the cardiac surgeries where they have to stop the heart and they need to defibrillate to bring it back up or something, how do we, that setup, what do we do? What's the usual thing or what's recommended?
Yeah, so we have paddles available to be kept on the epicardial surface of the heart when there is, VFib detected, or perhaps even a TTP or a polymorphic VD, whatever it is, and you have a hemodynamic compromise. But I'm not sure if that's available, that frequently, because those centers which have a massive volume of bypasses, we have them. So that's what I'm saying. So it's all about the center itself, where you, while on patient on table, intubated, still goes as a VFib, there are ways to defibrillate if required.
Yes, we do have them. We have those paddles, as well as the cables that makes it compatible with the defibrillator.
Yes.
We have them in our center, but the guidelines on, just want to be aware what to do or how is it done. I'm not familiar with that space yet, but since I have
there's a specific set of technical requirements while the patient has been opened up. You have to be ready for all cases. So there's a specific group of technical people always ready with those paddles in case there's a VFib. Again, these are not in the guidelines, because once you've opened up the chest and you are, the usual circumstances will be once you are on a pump and both off pump or on pump, you've taken care of this VFib part. But again, arrhythmias can happen anytime. So there's a technical team which is always ready with those paddles, and in case required, you defibrillate them.
Okay, thank you.
Yeah, thank you very much. AJ, do you have something else to share with us? Amitesh, you have something else to share with us? Have we finished dealing with the topic? Defibrillation, cardioversion?
If there are no questions, if there are no doubts, I think we have. I don't have any slides as of now.
Yeah. So I've shared the slides in the group. I need to make some modification, but I just share it. We can, those of us who wants to go through it, because we have fellows from here too who are interested in much about it. If you have any questions, you can post it in the group. You can post it to Dr. Amitesh. Dr. Amitesh is in the group. You can get his number from the group. Yeah, you can ask him any question. If you want to ask AJ, you can ask AJ any question. You can ask Elvis. You can ask me. The aim is for us to really understand these things and how they work and how we can get our patients managed better.
Absolutely.
It's already, I can see that it's after 12 in Delhi, 5 minutes past 12 in Delhi.
Yeah. We've gone past 12.
Sorry, we have kept you awake now. Yes.
It was good. Yeah, it was good.
It's good. So while in Nigeria here, I think it's 7:30, we have spent an hour, 30 minutes going through this topic. We have our teacher here also, Dr. Oga. Dr. Oga was one time the president of the Nigerian Cardiac Society, a very seasoned cardiology. He's my teacher. He's still my teacher to date. He's here. I don't know whether he will have a question, he will have a contribution to us on this topic we just discussed.
Sorry, Dr. Edafe, thank you very much. Actually driving.
Thank you, sir.
I'm sorry I joined
great.
late. I joined late, so I want to thank our teachers from outside the country, but I would like to get the slides as well, because I had another meeting, so I couldn't join at the beginning of the meeting. Thank you so much for
boss.
this session. All right, thank you.
Yes, sir. Thank you, sir. A very humble teacher and a great man indeed. So we have shared the slides in the group already.
Good.
So
Perfect.
I posted the slide in the group. Perfect. So AJ, you are taking next week.
Thank you.
Yes, sir. AJ, you have a topic next week, sir.
Yeah,
you
I think.
And Jared. Ask Julius.
Yeah,
you,
Julius.
You and
Yeah.
Jared. Well, Julius will moderate